Good afternoon, and thank you guys for joining us. It is March 22nd, 2020, and you are here to join us for the CAF COVID Weekly Roundup. Today we'll talk about, I didn't put the mitigation plan on there, but we'll mention how testing relates to the submission of your mitigation plan. We'll also talk about an administrator's experience. We're lucky enough to have an administrator join us that has had real world boots on the ground experience, and so she's going to share her experience with us a little bit later. And as a part of that, we'll talk about the infection control surveys and what that looks like if you've not already had it, and maybe some pointers to get you through that process. So most of the time we've been concentrating on doing weekly updates because we've had to address AFLs on a weekly basis. Lucky for us, well, I don't know about how lucky it is, but there's only really been one AFL that's come out since the last time we talked last Friday, and that was an update to the daily reporting. If you guys have issues with this, honestly, we don't know when it's going to get corrected. I know Patty is working, gosh, almost day and night to try to get this figured out with the state. If you're still having issues, please contact us and let us know so that we can forward on those problems directly to CDPH. And then we do anticipate testing guidance or recommendations to come out. I'm going to talk at length in a second here about what we anticipate that's going to be. And then many of you guys have seen, I've gotten a number of emails today pumping up the amount of money that they're sending to the skilled nursing sector through the Department of Health and Human Services at the federal government. So our understanding is those financial resources are hitting the buildings today, or the providers today. The reason why I mention that is because I think that is going to at least influence the decision on what kind of financial help we get in meeting the testing recommendations. And the only reason why I bring that up is because I think that is going to play a part in the testing. So I don't know that for certain, but I think it's logical to assume that they're passing out this money, and a part of their expectation is going to say that the testing and completing testing is going to be a part of that. So we'll talk about there's more reimbursement stuff as it relates to testing that we're constantly working through. And then I just wanted to mention that we spoke to CDPH on Wednesday about the Battelle system, the process for decontamination of N95 masks, and they're not finding a lot of people are using those systems. I don't want to encourage you to do it or don't do it, but I will say that if you're choosing not to decontaminate your N95 masks, either through the process is laborious, or it's confusing, or you just don't feel like there's a need to do it. I will say that the future for our supply chain is still murky. It's not, we don't know that this is, other parts of the world are not going to be impacted, and that's going to reduce the ability of us to be able to purchase those supplies. So in the interim, CDPH's recommendation is, since we don't know what the next 3 or 4 weeks are going to hold, or month, use those systems while we have them, since they're free of charge and the shipping is all covered, rather than toss those N95 masks. At least consider using the Battelle system to get them decontaminated and put them back in service. I mentioned the data issue is still not solved. One of the reasons why this is still important is it will help us track not just outbreaks, but the scale and size of the outbreaks. I think I've mentioned this before, but on April 15th, the guidance changed to call for universal masking or source control of all the folks in our building. And without access to good data, we can't really formulate, are the outbreaks subsiding? And when the outbreaks do occur, are they occurring with less impact to the building, whether it's less staff being tested positive and less residents? Since the data issue is kind of missing for about a week there, we really don't have a good idea of whether that's occurring. And so when we look at the data, and this is why I think it's important, I realize that those folks are having issues with the reliability of doing the data, but it's important for us to have the data because we can point the state to things that were successful, and we can say, hey, let's continue this based on the data. This is what they're seeing, and we're not the only ones looking at the data. The folks at CDPH are looking at it as well, to be able to, kind of pick the next thing that we need to work on. So it's important for us to get the data in. Once we get the data in a reliable fashion, we'll be able to kind of pinpoint those things that are working well in the buildings. So, and then I mentioned testing. I don't know why I put it on there twice. Maybe it's important and it's a big thing, but it's definitely coming. So what do we know on testing? We know the mitigation plan required us to have a plan for testing, and that plan should be made in conjunction with the local health department. We anticipate that is going to be consistent. So even if an AFL comes out from CDPH, our guess, and I think this is probably likely, is it's going to have a component where you work with your local health department to accomplish the testing. It's not going to be well, I think it's unlikely to be an end-to-end solution where the state sends out testing to the building and then it's done all in one fell swoop. I think it's still going to be passed out county by county, and then the counties are going to work with each individual provider to figure out what the testing looks like for your county. I will say there's probably going to be a set of recommendations that are going to look different than maybe what your county is doing now, and I'm going to cover those here in a second. So, all right. So what we anticipate is going to happen is everybody in the state is going to have to do a baseline test of COVID-19 for all residents and all staff. I can almost guarantee you that is going to be that's going to be at least the basis of their recommendations. Now, whether they mandate it or whether they bring it out as a recommendation, I'm not certain. I think more likely these are going to be recommendations, and then each individual facility is going to have to confer with their local health department to develop a testing plan. It's going to take a whole bunch of work for you guys. I realize that we've, talked to the state about, gosh, if we're doing all these things, we almost need to have a separate staff member to just do testing. So the baseline will be, that's going to be a minimum, I think, for sure. As a part of that, they're going to recommend testing all admissions and readmissions to a skilled nursing facility. So that would mean guidance to the health departments to make sure that the hospitals were testing residents prior to being discharged to a skilled nursing facility. We assume that anybody that's symptomatic, whether it be a staff member or a resident, if they're symptomatic, that's going to cause the facility to need to test everybody in the building. And I think that's probably good practice. That is consistent what we've seen in most counties already, if they've had the capacity. Los Angeles is a great example. Any symptomatic resident or staff member, they come in and test that person. If they get a positive test, then they test the remainder of the building. And then we've not really talked about doing this, but I think what we really have to flesh out, and I know a lot of you guys have already done this, but there are folks that have not started this process yet. So you're going to need a process of how you're going to get these test kits collect the test kits, and have a relationship with a lab to have the test kits tested and then the results sent to you. So it depends on the county. Some counties have access and to public health labs, and they'll be able to accommodate within their local health department's testing capacity. But I'm not sure that applies broadly to every local health department. And so for those local health departments, be prepared if your local health department does not have the capacity to do this in-house, that you're going to have to come up to some kind of arrangement with a lab. The state we asked the state earlier this week, okay, traditionally our lab network is pretty small and segmented out for skilled nursing facilities. So I know there's a greater list of labs that have resources. Can we get those lists of labs and the labs that have the test kits, that have the ability to read the tests, can do it all internally? They've been working on a list of labs that meet a specific criteria, like they're CLIA approved. They do the type of test that's going to be required, the PCR test with a specific sensitivity to make sure that we're catching folks. They have a list of that. I'm assuming that when they issue the AFL, that list of lab resources is going to come with the AFL. And if it doesn't, we'll get a copy of that. I know they're also going to post it on the Testing Task Force website. I think it's testing, well, let me find the exact website here because I didn't list it for you guys, but it is testing.covid19.ca.gov. And my guess is that when they come up with the AFL, they'll probably attach it to the AFL and they'll probably list it on this on that website. And then as they add more labs to the list or take labs off, I'm assuming that's where the master list of labs is going to be housed. And if you're concerned about the numbers, like will there be enough? Just from an initial look at some of the labs that they have listed. Obviously, the big labs we know of, Quest and LabCorp are listed on there, but there are a number of others that don't necessarily always work in our spectrum of healthcare. But it was more labs than we had previously thought. So that's good news if we're looking at access to testing. What the throughput of those labs are, I'm not sure, but at least it gives us options, which is always good. All right. So the recommendations are going to be everyone that's not already tested to have a baseline. And I'll just say, if somebody's already tested positive, and they've met the 14-day criteria for removal of transmission-based precautions and all that, or you've gone through the process of getting them a second test, and gone through that process. The point is, if somebody's tested positive, we don't have to retest those folks again. We know what their status is. So we're only talking about the folks that have not received testing yet. And then we think it's likely that they're going to recommend 100% of staff tested at least monthly. We know of specific counties that are doing even greater testing of staff. Tracy will talk about what Santa Clara is doing in a few minutes. But those we anticipate that since the staff is the primary vector of this coming into a facility, we anticipate most of the focus to be on frequent testing of the staff. There are some recommendations for ongoing testing of residents, but it's more in outbreak management. And then we'll talk about, we still don't know what to do with staff that refuse to get tested. And I don't know if this is going to be a big issue or not. I talked to a few providers that have said that did not happen, but it doesn't mean it won't happen. And we're still up in the air of what that looks like. It may be up for, there may be an allowance for you to come up with your own process of what to do with the folks that refuse refuse to get testing. I'm not sure if CDPH is going to weigh in on that, but we've certainly asked them, what are we supposed to do with these folks that refuse? The other question is, what do we do with data collection? We know a big portion of this is going to be incumbent on you of not only doing the testing, but collecting the results. And we're going to assume at some point CDPH is going to ask for those results, and whether it be as a part of the survey when they come out for infection control surveys, or what that looks like. But anticipate a big portion of this will be the logistical challenge of getting people tested, keeping records of the testing results, and implementation of your mitigation plan if you have any positive cases. We anticipate that a portion of this will go into communication. So communicating with the staff, the residents about the status of the tests, what testing is going to look like within your building, and then obviously notification of the families if you have any positive cases like that. And then serial retesting. I think the goal is for these folks is to really concentrate on the staff. They will call for retesting, I think, for residents, but mainly as it relates to outbreak management. So you test once, you have 4 positive cases, you test again in 7 days to see if you have any more positive cases that you didn't catch with the first test. Those kind of things. There's going to be probably some component that's going to require you to retest after that if you have positive cases. And then a part of whatever the testing results are, that's going to influence possibly staff shortages. So if you kind of see this holistic view, how testing kind of leads into the implementation of all those other things that they required in the mitigation plan. So your testing is going to dictate what you do in your mitigation plan, how you cohort people, and all that. So the testing is kind of the basis of where we go with the rest of it. Yeah, so I just mentioned this, but essentially residents that are, if you get one positive person in the facility, they're going to treat it like it's an outbreak, and they're going to want you guys to retest everybody 7 days later to see if you missed anybody during the first round. And then we talked about the cohorting thing. The kind of gist of it is 3 real categories, and there's discussions on whether the exposed people go into the positive thing, but let's just say there's going to be, you should have 3 buckets. 1 definitely positives, 1 definitely negative, and then that other category of yellow or caution for exposed residents. I think Tracy can talk about her experience and what that looks like in the building. And then the last part is staff. We know, if any staff member tests positive, we're going to retest every 7 days until we meet that 14-day total. And then any staff that does test positive, if you have a COVID positive unit, that staff can work in that COVID positive unit, provided they're going to be asymptomatic and willing to work, but they cannot work the negative folks at all. We don't want them working with anybody else. So, all right, I think I went through like a shotgun blast of what we think are going to be the testing recommendations. I know we're going to have a bunch of questions, and I didn't get a chance to get to questions last week, and I want to leave some time for questions. But I thought it was important. I've been trying to coax, convince, bribe a nursing home administrator come in and talk about their experience. And luckily for us, Tracy Murray sits on our disaster advisory group with CAF. So she has some familiarity with our disaster preparedness program. And I wanted to have her come just talk about her experience, like how she discovered she had COVID folks what that looked like, the feelings from her staff and things like that. Tracy, I want to thank you immensely for joining us and sharing your experience with us. Can you just give us a rundown of kind of how you discovered COVID the first time in your building?
Sure. First, Jason, I wanted to say thank you to you and to CAF for asking me to be a part of this presentation. I listen to the weekly update every week, and I find tremendous amount of information that I've been able to use throughout this pandemic. So thank you for doing this. I also want to thank Generations Healthcare, because without both their corporate support and the individual administrators, we would not have been able to make it through the outbreak. It takes a village, and they were really good at getting ahead of things and planning and strategically providing things, and it was just amazing. So I think a lot of people in CAF know me because I've been a member for over 30 years. But just briefly, I've been running nursing homes as a licensed administrator for over 30 years. I'm also a licensed attorney, and I serve as the regulatory advisor for Generations Healthcare. I've been in Cedar Crest, my current facility, for 16 years. And when this whole pandemic started, and I did what most of you did, and that's I worried and I hoped and I prayed that it wouldn't hit us. I had participated with my facility, in this facility, with a CAF pilot program a number of years ago on handling pandemic influenza outbreak. So we had a little bit of a head start on most facilities, having the policies in place as well as some of the supplies. And most of my staff had gone through that training with us. I was lucky to have my DSD knew how to fit test N95s because of that training. So thank you to CAF for that as well. That helped us. So how it got started at Cedar Crest, we had one really, really helpful CNA on the PM shift. And of course, he was asymptomatic when he was spreading the virus, as over 44% of people are asymptomatic for up to 5 days before they test positive. And by the time he tested positive, there was a small group of his residents on his assignment that started to show symptoms. Pretty soon, those residents tested positive, and within a few days, the day shift CNAs who cared for those residents began to show symptoms. And then it leapfrogged back and forth between the staff and the residents. Once we started having the positives, we had mass testing. And I'll just say a few positives and negatives about mass testing. It did allow us to protect the negative staff and residents. We found out that about a third of our residents that were tested, that tested positive, were asymptomatic, and we would not have known had we not done the testing. Half of the staff that tested positive were asymptomatic, so we definitely would not have known, and they would have carried it to other residents. It did give peace of mind to our residents and their families, as well as to our staff. The negatives was, well, we lost a bunch of staff while they were on shift because they got the call that they were positive and they had to go home and quarantine. Once a number of our staff, once they found out that they were negative, they were afraid to come back. And some of the people who were positive were told by their counties that they had mandatory isolation, so they were afraid to come back. Another negative was the what shows on the internet for your total numbers. And thank you so much for CDPH for posting those numbers so everyone can see them. Is that they don't show the background to that. They don't show that they were asymptomatic. They don't show that most of them did not come down with bad symptoms, and that most of them remained well during the pandemic. So they don't show any of that. So our families, knowing what happened in Washington State and New York, assumed the worst and assumed that this was a morgue, which it couldn't have been farther from that. I'll give you some hints on what really helped us to contain it and make it through. I was very, very fortunate that I had my assistant administrator, Bethany, who took over the communications. And that was a vital part of our success. As we found out later when AFL started to come out and as we had our COVID focused survey. But I'll tell you, when we first got our positive, first 5 positive, we erected a barrier in the wall, in the hallway, which was a fixed wall with an opening large enough to, of course, take beds through. And it had vinyl doors that zipped up. And we did follow Jason's recommendations to do daily checks on those, by the way. But it did provide immediate access were we to have an emergency. We also provided our staff who worked in the COVID unit with an RV to take showers before they went home. And as soon as we got the positives, we moved them into that unit. The communication started with a mass voicemail that was sent. It was a robocall. And we were able to send that out to all families and all family members to let them know that we had COVID in the building. And that was when we had 5 positive residents. We gave them Bethany's email and her private cell phone so that they could establish contact if they couldn't get a hold of someone at the facility. Even if she couldn't answer their question, she could get the answer and get back to them. When we were dealing with it at first, we had more time. You know, we had set things up, we had a plan, but you know what they say, how to make God laugh is you make a plan. And so that plan soon changed as our COVID unit was too small. We had to expand it and move down the hallway. And eventually we flipped it to the opposite end of the building and took an entire station to handle our COVID outbreak. We found that you have communication coming in so fast that you don't have time to process everything. So we developed a system where we used a binder with tabs for each day of the month. And as things came in and as we handled things, we put them in that day. And at least that way we could go back and check when something happened or when someone sent us a communication because it was under that daily tab. We also found that the easiest way for us to make sure that all family members were contacted when there was a change, or we established a weekly call for every family member. We took our roster of residents with their family members' names, and we divided it up amongst our managers. And as they took their portion, they'd fill out who they spoke to, date and time, and then we'd collect them all and put them back in the binder under that tab. That way, when we were asked by licensing if we could show that we had actually contacted people, we had that information by date, and we could show that we actually had informed our family members and had communication along the way. We also found that with the tabbed binder, it gave us a place that we could store the things that were used later for our COVID focused survey. So that was really, really helpful for us. The facts about our outbreak, in 12 days, we went from 0 to 38 residents, and 3/4 of them were our long-term residents in our facility. During this outbreak, we had a total of 44 residents that tested positive. Most of the residents stayed healthy with mild symptoms or no symptoms at all. We only had a few that had any problems, and they were mostly respiratory. We did have 5 residents expired during the outbreak. We were able to maintain our staffing levels throughout the ordeal with our own staff, but this was largely attributed to the fact that Santa Clara County allowed us to have our asymptomatic staff work in our COVID positive unit. We did not have one single staff member test positive after we put on masks. So my COVID outbreak in my facility started on April 2nd, and that's the day that licensing actually suggested that we put on masks. Before that, we had been told not to wear masks because we wouldn't have enough if we had had a surge. So we're very strong believers in N95s, which we wear to this day. And we know that the combination of the N95s, PPE, hand washing, and sanitation of high touch areas really does work. For Santa Clara County, they initially had a double negative standard for allowing people to come out of the COVID unit, meaning that they had to have 2 serial negative tests. But last week they went to the CDC standards of 14 days post-diagnosis or 10 days post-last symptom, whichever is longer. And with that, we were able to open up our COVID unit and become one facility again. We did have our COVID focus survey, and I'll just touch on a few of those things that they really focused on in that survey. We had, of course, they wanted to see our infection control policies and procedures. If we had a COVID specific policy and procedure, which we did. They wanted to know how we communicated, and they wanted to see how we did that, which we were able to show them because of our tabbed binder. They wanted to see our reporting and how we had done with that. They asked to see our surveillance log, which most of you, I'm sure, keep an infection control surveillance log. When you see a COVID unit, it's basically all the dots are on one area of the building. So I thought that was kind of silly for them to ask, but they did. They wanted to know how we made sure that we were having disinfecting on high touch areas such as handrails, doorknobs, and such. And they wanted to know about wet times and how we made sure everyone knew the correct wet times for cleaning those surfaces. They wanted to know about staffing. That was very important to them, and how we staffed the COVID unit. How our PPE supplies, they wanted to actually see them. They did a brief tour, and they wanted to know about all of our in-services and how we trained our staff on PPE, hand washing, and disinfecting. And from start to finish, it was 6 weeks. And we still have not had a single staff member test positive after we put on our masks. So that's what happened at Cedar Crest.
I'm sure there's probably some very similar stories all across the state. But for those of you that have not had to experience this, I wanted you at least get a flavor of what this looks like in a facility. When you guys were taking people, moving, did you reduce the size of your COVID unit as it went, as people met the time criteria, or did you keep it the same size until everybody was done?
We had only moved 2 people out of the COVID unit when they started the double negative testing, which we ended up moving them back because they still tested positive, which now they know that's more than likely they're going to continue to test positive. As we started doing our testing, we only had a few people who made the double negative. And so we were able to move 8 people out of the unit. The other people remained in the unit as we were trying to get 2 negatives in a row. And then one day they just told us, no, we're not going by that standard anymore. We're not going to test any more of your residents if they've gone 14 days past their diagnosis or 10 days past their last symptom. they're done. And it was over, just like that.
Yeah.
And we
I
were able to open up the unit the next day.
Yeah, and I think given you know, the amount of testing that we're going to have to do as a part of these recommendations, I think that's probably going to be likely. The likely experience of most providers is they're not going to be able to do the 2 serial negative tests, and they're going to have to do the time-based or symptom-based or whatever they call it, the time-based strategy. So in terms of family members, what kind of feedback did you get from family members about how you were communicating? Was it enough? Did they feel like it was adequate? I just want to know, is there anything best practices we can do with helping the families that you could think of that we could pass along to folks?
Sure, thanks. That's a great question. We had, like I said, we had one person who was the point person, and that was my assistant administrator, Bethany. She did a great job at coordinating, communicating with the families. We had some families who wanted to hear daily, and we had one family who said, well, if he dies, call me then. So I had, and everything in between. And she kind of made sure that everyone got enough calls. And we had just a weekly call from the nursing staff on top of that to make sure they were getting an update for nursing. The rest of the time, we were the ones who were driving the communication. And I had great feedback from my families. They were very appreciative of our transparency and the fact that we dedicated one person to, being the liaison and to communicating. She also facilitated all the FaceTiming, and I mean, I'm not an IT person, but FaceTime, Skype, Zoom, however they wanted to communicate, she made sure that it happened. And I have told other administrators, if you have one person, if you're doing furloughs, if you're down beds, if you have any way that you can just bring one person back or have one person dedicated to that during an outbreak, it is imperative to have that communication.
We all need a Bethany. That's what we need.
We do. We all need a Bethany.
So the other question I get frequently is, what do I do with media? Especially, Santa Clara's been pretty heavily impacted, so it almost seems like maybe the media attention has spread out. But for communities where maybe there hasn't been this kind of media attention, did you guys get any media inquiries directly or have to respond to that at all?
We did. We actually, on my first robocall that I sent out, I had one of my family members forwarded it to the San Jose Mercury News. How kind of them. And I elected to not respond to the media. We were fortunate that we had all of our residents remained in-house. I think that's why we escaped a lot of the media attention, because we weren't sending them out to the hospital. They just stayed right here in the facility. So I don't think we got as much media attention because they couldn't get any information. So I did have some inquiries from the San Jose Mercury News and the San Francisco Chronicle, and they call and say, we need you to respond by noon today. We've got a deadline. And I thought, well, that's nice. And I did not respond, and purposely. I didn't have the bandwidth at that point to deal with the COVID outbreak, my staffing, making sure everyone was taken care of, and dealing with the media. So I don't necessarily think that's the right thing to do, but that was how I handled it.
Yeah, Tracy, I think your experience is probably more realistic. I have to deal with the media, and I feel like I'm walking on eggshells the entire time I talk to them. So it's, if you're not familiar with dealing with the media and you don't have a prepared set of talking points that you're going to talk to and stick to those, I think you can almost do more harm than good, you know, with the media. So I just want people to know that you're not obligated to answer those phone calls, and Tracy's experience can apply to you guys as well. In terms of like surveillance testing, what are you guys doing for the folks that have not tested positive but are still in the building now? Are you doing any surveillance testing?
We were required by the county to test all of our negative residents before I opened up the unit. And so we did, and they all remain negative. And we are now just required to monitor as if we have a PUI or anyone who shows any symptoms, which fortunately we have not had that happen yet. And I'm knocking on wood. We also are required to test our entire staff every 2 weeks. And as part of our, you know, and they asked when I had some of our staff who have not tested, and they're asking me, when are you going to test these people? Are you going to allow them to work if they haven't been tested? And each of the people who hasn't tested haven't worked. I mean, they haven't been scheduled. They're per diem and they work, you know, once or twice a month. And those people just have not been into work. So I'm not requiring them to come in and test if they're not going to be working in my building.
And you're doing the testing yourself. You're getting the test kits and then you're sending them to the lab. Well, you're driving them to the lab, but essentially you're doing the testing, not another party's coming out to do the testing, correct?
That is correct. We, I think because we had such a large outbreak and we were so early on, we've been the test case for Santa Clara. And so they have kind of set policy based around their experience with us. And they did figure out that it's easier if they give us the test kits and we do the testing. I think because it was such a large outbreak that that's why they're requiring us to do the testing every 2 weeks for the staff.
Yeah. Well, I think that experience is probably that experience of you having to do your own testing and not having a public health nurse come in and do the testing. I think that what that looks like is going to be probably what most of the providers are going to have to do in their building. We don't know that for sure. We don't know what the capacity is of those local public health labs to be able to come in and send a public health nurse to come do all the testing, but we think it's probably more going to look like what your experience has been. So before I open it up to questions, was there anything else about your experience that you think an administrator or a DON or a DSD might, you know, some of those things we did not think of that now, had you known, maybe I'd do it different? Is there anything that you have for that?
I think that, you know, you can make all these wonderful plans like we did, and I think you don't realize until it really hits, and it moves so fast that and it's so overwhelming. And I have to say that a lot of the administrators in our area and DONs reached out and said if we needed anything, they were happy to help. So I think that it takes a village. And I appreciate all those who did reach out to me and to my facility. You know, we've been able to help a lot of buildings since, and just, you know, help each other. I'll tell you, because none of us can do it alone.
Yeah, that's a great message that we try to preach, that we need to help each other as much as possible. I keep waiting for the folks on the, you know, the white knight or whatever they call it. I keep waiting for them to show up, but I don't think it's going to happen. And we've got to really, in this situation, we really got to reach out to help each other. And whether it's through support, just making a wellness phone call with your fellow administrators to see how they're doing, or material support in the manner of supplies or staff or whatever it is, or expertise. Let's have this open forum of that so that we can all beat this together. I want to thank you, Tracy. This has been fantastic. I learned a lot from listening to you guys talk about your experience, and it helps influence how we advocate for on your benefit at the state. So Courtney, if we've got some questions, I'm not able to see the questions on the chat box, but maybe you can read off some questions from folks.
Absolutely. Can you hear me all right?
Yep, I'm great.
Okay, great. So there are a couple questions for Tracy. If Tracy, you have a couple minutes to stick around.
Sure.
So one person asked, was the staff in Cedar Crest only working in one facility?
Yes, we had all of our staff were either in the COVID positive or COVID negative end of the building. I didn't intermix staff. Like I said, I was very fortunate that our county gave us a waiver and allowed the asymptomatic staff to work with the COVID positive residents. But I did not mix between the two, and they only worked for generations, they only worked in my building.
And did they have part-time jobs in any other, did you have any CNAs that worked in other buildings?
I know that I do. I know that some facilities said that if they worked here in a COVID positive environment, that they were not allowed to work in those other buildings. So I know that some of my staff were not able to come in, and some of my staff chose to work with us and not those other facilities. The COVID positive staff, they did choose to work here because they could, and they couldn't work in another building. So we're just lucky, and it worked out. I have a lot of long-term staff, so I was very fortunate that I was able to retain my staffing ratios with my own staff.
Fantastic. Next question, Courtney.
Let's see. So how many people did Tracy test per day, and was the test done per shift, or did you call them in?
We let staff know when we were going to test, and we did it over, I say it like we don't do it all the time. It seems like we're always testing them, but we usually do it over a couple of days. And if we're unable to catch somebody, then we will get them the next time they come in. But we just post when we're testing, and most staff come in and get their testing done right then. And I have a few of my nurses who are trained and who the county observed them doing it. So they sanctioned those nurses to do the testing.
So did public health come out and say, we want to witness you guys taking the specimen collection to make sure you're doing it correctly?
Well, we had a number of times where they came out to the facility and were testing residents, staff on their schedule. And during that period of time, we told them that we would be happy to do it. And they observed my nursing staff doing the testing and said, okay, you know how to do it, we'll allow you to do it. Okay. So it wasn't a set planned thing. It was kind of evolved.
Right. And I think that's kind of what we've heard from other counties as well, as they'll witness the collection, make sure that it's done in a manner that's consistent with best practice, and then they'll let you kind of go from there. So next question, Courtney.
Yes. So I believe this one is still for Tracy. Did the nursing staff change all PPE after taking care of 2 cohorted residents in the same room?
When we started and we had PUIs, we did the preserving of PPE by using the PPE in that room, and we limited the number of staff. But once we went to the outbreak, it's kind of there's before and after. Once we had the outbreak hit, you put on a set of PPE and you wore that your entire shift in the COVID unit. Those who were working in the COVID negative side, they would don PPE, one set, and after a week, we were told by an infection control specialist that we no longer had to wear PPE in the COVID negative side, which drastically cut my use of PPE at that point. Of course, they still had to wear masks and gloves, but they didn't have to don the rest of the protective equipment.
Did you have a selection process for choosing staff for the cohort zone?
If they had a pulse, we let them work. So
Right.
the selection process was they were willing to go in and they were part of my staff. And that was about as far as we went. I didn't exactly have people breaking down my doors to work in that unit. So it was, we did provide hotel rooms for those who worked in the unit. I had a number of my staff who were not allowed to go to their homes after working in the COVID positive unit. So I provided hotel rooms for them. We did provide meals at the facility daily for the staff because it was difficult, especially at the beginning. That was in the beginning of April. It was difficult for people to get out and get meals. So we just had them provided in the facility.
Okay, and we have a question from Calvin. Were you using face coverings prior to the discovery of the symptoms, or did you start wearing them after?
The actual beginning of the outbreak was in the end of March, and that was before masking was thought to be beneficial. I'm not sure how that happened, but because it was the end of March when our staff member was actually spreading the virus. It was on the 31st of March when Santa Clara County actually announced that they thought it would be good for everyone to wear masks. Up until that point, we were told we shouldn't be wearing masks because there wouldn't be enough if a surge hit. And it was on the 2nd of April when the Department of Health actually came out with guidance that they thought we should be wearing masks. So I already had the outbreak in my facility when face coverings were suggested.
Next question, Courtney.
Yes. Did you have any full-time staff members or residents that refused to be tested?
I have not had any staff members refuse to be tested, although with our testing happening every 2 weeks, I could see that maybe they might get a little tired of it. However, after you go through the ordeal of having half of your building have COVID positive, you kind of see the importance of it. So I don't know that I actually will have staff refuse. I have not had them yet. I initially had one resident who refused, and we treated her as a PUI. And but then ever since, she's been willing to be tested. So I haven't really had any residents refuse.
Okay, and there's a couple questions. I'm going to try and combine them. So what kind of masks are your staff wearing, and are they all wearing the same, or is it different by area?
We are wearing N95s. At this point, we could switch to the surgical masks. I have told my staff that we will continue with our N95s at least for a few more weeks, just because once bit, twice shy. And I made them a promise, so I will stand by that. When we had the COVID outbreak, we had a number of people donate masks, especially masks, but also gowns and gloves. So it was amazing. The community came together, and a lot of our resident families donated. I don't know how they got these things, but they did. So we are able to still use our N95s. We are using extended use. And I do have the ear loop available for all of my residents.
And is that for only nursing staff for the N95s or ancillary staff as well?
That is for all staff.
Okay, great. Let's see, we have a couple questions back to the testing. Were the tests done by RNs only, or can they be done by LVNs? And then which lab did you use?
We are required to get our testing done through the county. So we use the county lab. And I have both RNs and I have one LVN. I volunteered to do it, but they didn't want me to. But we are having both RNs and LVNs.
And are those nasal or nasopharyngeal swabs?
I believe they're nasopharyngeal swabs.
Yeah, they're the ones that go all the way back.
Yeah, they get a little brain matter in them when they do it.
Yeah.
Of course, I'm being facetious. It only feels that way, but yeah.
And
Okay.
and those folks, when they're doing the testing, they're wearing full PPE, correct?
They are wearing full PPE. We do it. It's like at the grocery store. You get it, you move on, the next person comes up, and so they are wearing full PPE and they are changing their gloves in between.
Okay, were you able to get everyone fit tested for the N95s and get the brands that you needed?
Fortunately, yes. My DSD was part of the pandemic flu pilot, so she was actually taught how to do the fit testing. And there was a certification back then. I don't know if it would still hold true, but she did know how to do it from that training that she had gotten before. So we did fit test everybody on the N95s that we're using. When we had the initial outbreak, we were given some other N95s, and she fit tested everyone for those as well over in the COVID unit. So she was able to do that testing in-house, that fit testing.
Okay.
And I just want to be clear, people can purchase test kits and they can do fit testing themselves if they're concerned about doing that. There's a number of places that sell test kits that you can purchase and start doing them yourselves.
Alrighty. So Jason, I see a couple other questions regarding the mitigation manual template. Do you want to answer those with our last couple minutes here?
Yeah, we got two minutes left. Yes.
Okay. So this question comes from Corey. CAF's mitigation template regarding testing states a baseline of 100% staff and residents and then 10% each month going forward. How has CDPH received this method?
That's a good question. I don't know for sure, but I think it's unlikely that they're gonna follow our recommendation. I think more than likely it's going to be substantially more than that, and probably is going to be whatever the equivalent is of 100% of the building on a monthly basis. I don't know that for certain, but I think that's probably likely. Yeah. So, and I saw somebody else mentioned, could they buy test kits for the N95s? They just emailed me. You can buy them from like Grainger or any of those supply places. If you just put N95 fit test kit on Google, you're going to come up with a bunch of providers, vendors that could sell you test kits. They're not too expensive. Hopefully I answered the question on the mitigation plan, but I really think, guys, we're just days away from the state recommending that 100% of the staff be tested at least monthly. All right, next question, Courtney.
Yes, our facility does not have COVID positive residents. Only one staff tested positive and she is back working now. Do we still have to do a baseline test of the whole unit?
Yeah, I think that's a given. We're going to see that's going to be a requirement. Well, I don't know if it's going to be a requirement, but it's going to be a recommendation, and which, although it doesn't have the same legal authority as a mandate, it certainly would not look good if they recommend you test 100% of people and you don't test anybody. It's not going to be a good look. I don't think we're going to be able to, even if you wanted to not test, I just don't see a way going forward. And I'll just be clear. I really do. And Tracy's experience, I think, is realistic, is that the identification of this in your building, if it happens, is extraordinarily important to be able to divide up those spaces. So I know it represents a whole bunch of work on your end, but it really will help formulate how you can best protect the people in the building. And knock on wood, you hope you test and you get nobody. That's great. And we can move right to surveillance testing after that. But until you do that test, we don't know. And your trepidation about what those results may bring should not overcome, the good results of getting those test results. The good work that can happen after that. So, and I'll go one more question, Courtney, before we hang up.
Yes. Do we still need to retest a newly admitted resident for skilled care if that resident tested negative within 3 days with no symptoms from date of admission to the SNF?
Well, one test is not necessarily, that's a prevalence in time. And until you're going to do the second negative test, if you're not doing that, then you should still follow the time-based criteria for the removal of those transmission-based precautions. I just think that this is a vector of how it comes into our building. And so if you have the luxury of having a space to observe those folks before you put them in, cohorted with the remainder of folks are negative, then I think that's the best plan. I realize that may not be feasible for everybody, but if you're going to give yourself the best chance of keeping this out of the building, that's one of the strategies that you could take. All right, guys, I appreciate all your time. I want to be respectful of folks, the remainder of your Friday. We got a long weekend ahead of us. We've got a lot of work to think about and how we're going to do this testing. Just know that if you have specific issues with your county, I want to hear about those. Please email them to me if you're having issues setting up testing with your local health department. I need to know who you are and what county you're in, but email me directly and we'll follow up and try to get clarification. I know that the CDPH, a lot of this is going to work in conjunction with the local health departments. So we're going to have to continue to advocate in multiple avenues. So as you get those things, and I got the emails from you guys saying these folks in these counties aren't being tested from the hospitals, and we've given that information to them, to the state, and said, look, we need to do better here. So those kinds of things we need to hear about. If we don't hear about them, we can't address them with the state. But if you email me, I promise you I'll bring them up to them. So I want to thank you guys again. Thank you very much, Tracy, for hanging out with us, for taking the time out of your Friday. And hopefully you guys enjoy the rest of what's left, or enjoy this 3-day weekend. Go get some R&R before you come back and think about this on Monday. Thanks, guys. Have a good weekend.
Thank you.